Imagine a world where people are not discharged from hospitals into homelessness. And when it did happen, even once or twice, hospital leadership would call an emergency meeting to ask, how could this happen? How do we make sure it never happens again? That world once existed in London, Ontario in the 1980s, where today's guest, Cheryl Forchuk, was a mental health nurse. But over the next 2 decades, she watched this rare occurrence grow into a full-blown crisis. She responded by building a large coalition to study the intersection of healthcare and homelessness, and to design programs that stopped discharges to no fixed address. In this episode, we'll unpack some of that research. In one early study, her hospital hired a housing support worker to connect homeless patients to income assistance and to housing, and 6 months later, everyone who got support was still housed. But almost everyone who received treatment as usual remained homeless. The result was so stark, and the status quo so clearly unethical, that Dr. Forchuk never again used a control group. Instead, her team focused on scaling solutions. In their next study, they prevented nearly 250 people from being discharged into homelessness, and the cost? Less than the cost of keeping a single family of 4 homeless for 1 year. These programs require coordination between healthcare, housing, and income support sectors. Dr. Forchuk's team has created systems to make that collaboration more simple and published implementation guides to help others do the same. This is a big deal because her research shows that more people experiencing homelessness interact with the healthcare system than with the homelessness sector itself. That means the health system could potentially prevent more homelessness than even the shelter system. It also matters for hospitals and patients. Homeless patients take twice as long to treat, so it costs twice as much. And when discharged without housing, they're far more likely to return to hospital and sicker. A bit more about our guest. Dr. Cheryl Forchuk is a research chair in aging, mental health, rehabilitation, and recovery, a professor at Western University School of Nursing, an assistant director at Lawson Health Research Institute. And just this month, she was appointed to the Order of Canada, the country's highest civilian honor, for, quote, her groundbreaking transitional discharge model that ensures people experiencing mental illness and homelessness are treated equitably and provided with the resources they need to rebuild their lives. In Canada, where we believe in universal health care, what would it take to treat addressing homelessness as part of that system? Let's dig into that question with Cheryl Forchuk. Welcome, Cheryl Forchuk, to one of our episodes on the cost of homelessness.
Thank you, Tristan. Glad to be here.
Great. So there was a time in Canada when homelessness was rare in the 70s and even into the 80s, but then it started to grow as a problem. How did that look to you from the healthcare perspective? What was your experience?
Yeah, it's very interesting. And I think part of where it may have taken some of us a while to see it in healthcare is, again, that we've always had silos. But I often use the example when I worked for many years as an advanced practice nurse in a provincial psychiatric hospital at the time. If somebody was discharged into homelessness, we had to fill out the same report as a patient assault. And it was very rare. And I remember 1 year, it actually happened twice in 1 year. And that was considered so awful that we ended up with a whole leadership meeting and everything. How did this possibly happen twice in 1 year? How could this have happened? So fast forward a few years after, I was doing a study on our transitional discharge model, which again was developed through a participatory approach with people with lived experience, frontline workers. It would have great success locally, and we were starting to expand it out across different places. So we were going to 6 different psychiatric hospitals across the province, trying to implement this model, see how it would work. And then we were looking at the difference between implementation wards that were doing it and control wards, treatment as usual. So across the province, 6 different places, when we were doing the follow-up, because we were following them up for a year after, we were finding people in shelters. And I'm thinking, what the heck is going on? we go from this alarm at 2 in 1 year, and that hospital was also included. And across all 6 hospitals, we were finding some people had been discharged into homelessness. And if I didn't notice that, I also noticed that I was getting calls from shelters saying, what's going on here? We're getting these people coming in and we're not equipped to handle it. And I would say if I even missed that at that time, my oldest son was still in high school and one of his friends would come over quite often working on art projects together. His mother had a serious mental illness and the family became homeless. So there was all these things going on. So I got together with a number of community agencies. We started looking at that. We eventually developed a Community University Research Alliance to look at it. But essentially, we had a huge change in how housing was managed. It was devolved from the federal, national level down to the provincial level. Canada is actually the only industrialized nation in the world that does not have it at that federal national level. And then in Ontario, obviously, we saw a bad idea and decided how could we make it worse? Because this was during the Harris days. It was further devolved to the municipalities. And within the legislation that did that, municipalities had the option to opt out. If they were not interested in public housing or homelessness, they could just opt out. So there were some very major policy issues that were happening around the late 90s. And when you have that kind of change, it's not like the next day you see the implications. But if you're not building new public housing, for example, the buildings don't last forever. So over time, that just became worse and worse in terms of the capacity within the system. But I always say when I talk to people, I remember when it wasn't a problem, because if we can create a problem, we can also fix a problem. If bad policy can create it, good policy should be able to correct it.
So when you had that meeting with your hospital executives, when there was 2 people discharged into homelessness, I'm guessing that was in the 80s or...
Yeah, because I'm trying to think when I left the hospital, but yeah, it would have been in the 80s.
And then by the late 90s, I'm guessing, after
the
well, federal government downloaded.
Yeah, well, we even saw that around the 90s, but it took a few years for that to really have the impact. As I said, like at the time that it was downloaded from the federal to the provincial government, the contracts for public housing were canceled, et cetera. And so it meant new things weren't being built. So it takes time for those kinds of things to show up. So when I was doing that study, it was further into the 90s. When we had our first Community University Research Alliance, that would have been in the year 2000. That was when it was becoming more obviously a problem. But like when you change policy, it's not like the next day you always see it. Unless you're cutting people's income, then maybe the next day you'll see it.
So I think after you start to see this really prevalent across the healthcare system, you start to design some studies to look at whether there could be intervention in the hospital to stop the discharging people into homelessness. So can you tell us about your first studies in that area?
I had done some housing related work prior, like looking at group homes and different kinds of environments. But we have what's called a Community University Research Alliance funded through SHRP. So it was actually 5-year funding we got to look at a series of studies. So a lot of it was very participatory, bringing frontline workers, bringing people with lived experience together and talking about what were the issues. The first thing we did, we had 300 people a year we were interviewing and following, and about 40% were homeless, and then 30% were living independently, and 30% in group homes, and talking about various issues in relation to housing and mental health. With doing those interviews, I was really disturbed as a nurse, my background's in psychiatric mental health nursing, that when we talked to people who were experiencing homelessness and how they ended up, so many of them were talking about their journey of homelessness starting with the discharge from hospital. So I had been working, as I say, even that earlier study was around effective discharge planning. We weren't working to get people in the community to have them end up homeless. So I found that very disturbing. So we had a number of different interventions we were coming up with, for example, social enterprises, work programs to deal with poverty issues, different kinds of housing models, different kinds of strategies if somebody was homeless to help for different subpopulations. But one of our early projects was also how can we prevent discharge into homelessness, because that should not be the beginning of a journey into homelessness. Now, there's several feeders. I mean, discharge from jail, from the correctional facilities is certainly another feeder, as is aging out of children's aid, as well as a number of others. But we particularly focused initially on that hospital piece, because that really should not be a feeder in. So when we got that group together, because we had this cure and we talked about what are the priorities, it was the consensus, I think in year 2, that was our number one priority. I ended up with people from 26 different agencies wanting to help us with that issue. And so it was a very large group. And we talked about the systems issues and what could we actually intervene on, which it took us a while to figure out. But we looked at all the things that contributed to the problem, and then we ranked them. With 0 would be pretty easy to fix, and 5 is it would take an act of God. And nothing was below 3.5. So there were no easy fixes. But what we decided was an intervention where we would have a housing advocate to help them find housing while they're still in hospital, and to advocate, for example, if there was a threat of eviction or something like that going on. And then secondly, faster access to income support. So at that time, we had what was called a community startup fund, that if somebody was on provincial disability or provincial basic income support, they could access. But it often took 2 weeks to get that. Yet the average hospitalization, particularly in acute care, was not 2 weeks. And we started on the psych unit. So I worked with those agencies so that if they're in the intervention group, I basically called the boss of the organization if they were in the intervention group. And this was trying to test out if this intervention was going to work. We were going to take 20 people. So we had a housing advocate, and I would call either person from Ontario Works or Ontario Disability who was in charge, and they would fast track it. So often within 2 hours, they would have the check rather than 2 weeks. And we looked at our 2 hospitals in London. We looked at treatment as usual. And then half of them, as I say, we were going to do 20 people, but we stopped at 14 because it was like studying penicillin and syphilis. I should say, too, we really cherry picked the population. This was people with no prior history of homelessness, who had a stable income from either the disability or basic income support, and it was a planned discharge. So in other words, their mental health issue had been addressed. So that would be kind of the easy of the easy, and no prior history of homelessness. So we thought we'll just follow them for 6 months, even if they are discharged to homelessness with this kind of skill set, their mental health issues been addressed, it's planned, they've got income, they should, But anyway, what happened was the 7 people who got the intervention were fine. And in fact, by the end of the intervention period, 4 of them are actually able to get back to work and go off the provincial disability because their mental health issue had been addressed. They were in a stable place. 6 of the 7 of the people who got treatment as usual, I was quite surprised, were still homeless at 6 months. And again, because of the fact that these were not the people that you normally see with a lot of problems, stable income, no prior history of homelessness, and 6 months later, they were still homeless. They talked about that they felt like their life had been hanging by a thread and somebody cut that thread. The 7th person that avoided homelessness within that control group was recruited into the sex trade on the way into a shelter, never been in a sex trade before, and 6 months later was still in the sex trade. Statistically, we counted her as a success. And I put little error things there if you're only seeing the voice, because clearly that's not a success. But our outcome measure was housed, and she was housed. She would certainly not consider it a success. I don't think anyone would consider that a success. But we actually had statistical significance with that number. And that was the last time I did a control group looking at this, because it's like penicillin and syphilis. There's no point in having a control group. You let somebody go into that situation. It's just very bad for people. So anyway, that's what we did. But then we had to look at how do we bring this into usual care.
Yeah. And just to summarize that study design, you had 14 people, all of whom had not been homeless previously.
Ever.
This was their first time, ever. And half of them just got treatment as usual, as it's called. They dealt with them the way they normally would.
Like the social workers, they're trying their darndest to prevent it, but it didn't work.
The other half, the other seven, you had a plan and a strategy, which was to get them their income assistance immediately and have a plan for housing them.
And a housing support.
And housing support, yeah. And so just to be clear, you did this for up to 14 people. And the difference between the two groups was so huge that you had to stop the study because it was just unethical to continue. Is that right?
Yeah. Yeah. I called ethics and I said, I'm continuing to enroll people, but everybody's going into the intervention group and not into our data analysis until I can figure out. I remember talking to the people from Oregon Support saying, we got to figure out how to stop this study because we can't just stop it and do treatment as usual because then everybody's going to end up in this bad position. But I also can't really include them in the data. So we continued to house people while we were trying to figure out a way to make it usual care.
This might be a good time to introduce the concept of, or the analogy of musical chairs that I've seen you use many times, where the chairs represent affordable housing units. The people circling the chairs represent low-income people who require affordable housing. But then also there's the music, which is about these events that strike people and can lead them to homelessness, like a health issue in the hospital. So could you share your metaphor?
Yes, yeah. So that's a good summary. And I think the issue of transitions is important. And you think about music. Music is all about transitions. So when you lose your chair in musical chairs, it's because the music stops. It's because of that transition. Many people have used forms of this analogy. We thought we invented it, and then we found it in the literature. And then in our second book on poverty, mental health, and social inclusion, we found like there was like half a dozen people who seemed to simultaneously come up with it. But the chairs represent the affordable housing within a community. And by affordable, I mean someone on the lowest economic, so someone who is on basic income support, somebody who is on provincial disability, who's on old age security. What could they actually afford? So sometimes when we talk about things like Canada Mortgage and housing definitions, we're talking about 30% of your income. But I think it makes a difference if you're making $10,000 a year versus $100,000 a year. When you're talking about affordable housing, it's not a straight percentage. It's what about the people at this lowest level? Because if we have our basic income support set at that level, then theoretically we're saying someone could live on it. Then the people circling are the people at that income level. So clearly, if there's more people circling than chairs, you're going to have a homeless problem. So whether you pay attention to music or not, you will have a homeless problem. But the importance of the music is to look at periods of vulnerability, to look at these transition points where people may be particularly vulnerable. So for example, like the example I just used, coming out of hospital is a period of vulnerability. And as I said, I was very distressed to hear from people that it was a discharge from hospital that started the journey of homelessness. But that's an example of the music starting. And there's many reasons it could happen. Somebody could be, psychotic in the community or very depressed, can't even get out of bed and not pay their rent. So their rent ends up in arrears. It could be because the period of hospitalization was lengthy and they were unable to maintain payments. Having a diagnosis of a chronic illness is the music stopping, not being able to return to work, losing a job, relationship breakups, coming out of jail, retiring, an eviction, or as we saw in the pandemic, a rent eviction. So all these things are times when the music stops and you might be vulnerable. Now, sometimes just as in the actual game, you might be standing right in front of a chair when the music stops and you can quickly sit. Or it may be a time when you simply lose it. But the overall rate of homelessness in that community is going to be related to the chairs and the people that need access to the chairs. And if there's more people, you're going to have a homeless situation. Paying attention to the music is looking at these vulnerable periods where you could prevent it. When we did that study with these people with no prior history of homelessness in that very first study, it actually only took an average of 40 minutes of support per person to prevent homelessness for that group. Compare that, in some of our studies where we've looked at people who have had long-term homelessness, often 10 years. We find we have to work with them past a year to get them to truly trust that they are housed and they are safe. It may take a year until that knapsack is no longer at the front door in case they have to grab it because they don't trust, where they feel comfortable enough to put the pictures on the wall instead of on the floor. Uh, so it can take a long time, but yeah, preventing it in that example only took 40 minutes per person.
Yeah, that's an important consideration. Because they had not been homeless before, it was so much more efficient to prevent them from becoming homeless on their so-called homeless journey. And the hospital is a place where you could do that. I interrupted you a little bit earlier when you were starting to talk about what you took from that first study in terms of implementing
Yeah,
it and maybe your future studies. Could you, like your
yeah,
no fix
yeah. So
address project?
yeah. So we've done a number of projects related to preventing discharge to no fixed address. We started with the psych units. And as I say, we had a real brainstorming. Like, it can't rely on me calling the boss of Ontario Disability or Ontario Works. What we were able to do is put basically an algorithm on the social services website that if the request originated from one of the London hospitals, the boss automatically gave approval. So it was the same thing as phoning, except it happened automatically. And then we still had a housing advocate involved. And then around 250 people we provided service to the next year. And we only had two people discharged to homelessness. Interesting, both happened in the first 3 months before we had sort of worked the kinks out a bit, and both of them had come in homeless. So what we were finding is we not only prevented new homelessness, even when people came in homeless, we were preventing them from going out homeless. We've had many versions of that over the year. One of the problems was the province changed their database, so the algorithm no longer worked. So then we had to come up with another thing, which was designated people, that if the request came from certain people that were advocates at the hospital, then it would automatically get approved. We started on the psychiatric wards. We're very successful there. We went to the medical wards next because we were finding that that was starting to show up. And then we went to a youth specific version so that we could deal with things such as employment and education and pull those things in as well.
In some of that research, I noticed that your team did analyze the cost effectiveness
Mhm.
or comparing the cost of treatment as usual to this. And what did you find?
Oh, yeah. Like even that first one we did when we had the algorithm and the 250, we basically found, I think it was for the cost of preventing one family of four, if they were homeless the whole year, that would have paid for a housing support worker. And that was really the only additional cost was for the housing support worker, because what we did with Ontario Works, for example, with their staff, it was just a matter of them having a specialized team. They didn't have to hire anyone extra. They simply just reorganized the work so that they have people specifically working with the hospital. I'm very pragmatic. I think it's part of being a nurse. We can talk about our great results, but it doesn't tell you how to implement it. So we've also come up with implementation guides based on what people who've implemented across these various versions have found to be helpful. There is a version of that on the Canada Mortgage and Housing Corporation website. Also, if you email our team, we send that to people to help them implement it.
That's a great thing about your studies is that you had a really practical and simple approach to preventing discharge into homelessness. And when you look at the cost savings or
Mhm.
efficiencies, when you were preventing over 200 people from entering homelessness, that's a huge saving when the cost of the program to prevent it was almost negligible. And
Yeah,
you'd be saving, hundreds of thousands of dollars a month
yeah,
potentially.
and when we're talking about these people became homeless, their whole family would have been homeless. We figured that first year, at least 18 children would have been homeless when their family members were discharged to homelessness. So for the cost of housing four people, we were able to prevent homelessness with around 250.
One thing you've talked about is that people who have been homeless, when they enter the healthcare system, they tend to be there for longer and at a higher cost. Is that true?
Yeah, yeah. We've done some work with different ways trying to put numbers on things. CIHID, Canadian Institute of Health Information, recently released an infographic, and I was very happy to help be listed as a co-author of that. And basically, I mean, the thing is, when you're homeless, you tend to be very sick. Like your health is very much challenged. You can't maintain a good sleep pattern. You can't maintain a good diet. You're in overcrowded conditions. And so when people get sick, they tend to be very sick. So what that paper found, looking at national health data, so CIHI, Canadian Health, like they get the information from every province in the country from hospitals, basically. And what they found is it almost didn't matter what the diagnosis was. If you were homeless, went into hospital, because you're more sick, you'll probably be there twice as long. You could be in there with COVID. You could be in there with a cardiac problem. You could be in there with a broken bone, but it will take you twice as long to recover as someone else. And if you are discharged back to homelessness, you are very likely to end up readmitted in even worse position than the first time.
Yeah. And in your more recent studies, relatively recent studies looking at homelessness across Canada and the burden on healthcare systems, did you start to look at the cost burden of homelessness across the national healthcare system?
Well, as I said, like I think the CIHI data did that very well in terms of looking at it across the country. A part of what we were doing across the country as well is I think one of the problems with homelessness is we don't have accurate numbers. So we finally, just a little bit prior to the pandemic, did finally get a national housing homelessness strategy again. But the thing is, if the numbers of the total number of people impacted are not accurate, then you're not going to resource that plan accurately. And it's a really, really difficult thing to accurately measure. All of our traditional methods of looking at rates of homelessness relate to, in some way, the person has to touch the homeless sector. So whether you're looking at what we call HIFIS data or national databases, really shelter data. If you're looking at point in time counts, is that people are running around with clipboards and you look homeless. And with by name lists, you're looking at homeless services across the community and trying to come up with a name so that if somebody's using 3 services, they're counted once. But all of these in some ways mean the person has to be visible, and particularly visible to the homeless sector. So one of the things we did a few years ago was one of our versions of preventing discharge to homelessness. I was able to put in that grant that we would try to come up with an algorithm using health data as a way of trying to come up with more accurate numbers. So working with the provincial health data in Ontario is called ICES. They used to call it ISIS. They changed their name. I don't know why. Didn't want to be mistaken for a terrorist group, I guess. But anyway, we were also working with Stephen Huang's group in Toronto because he and I had data where we knew over time whether someone was homeless or not homeless so that we could look at whether or not we could predict or tell the difference between the two. So anyway, we were looking in the national study about could we take this approach more nationally. But when we looked at health data, it's also not perfect because not everyone accesses health. But what we did find is we found almost as many people in Ontario as the national numbers would suggest for the whole country. And we also know only half the people in our samples were actually accessing health care. So it would suggest we could probably, and again, we don't know for sure, but we could probably triple the current estimates, which explains why we're developing these programs and it's not enough to fill the hole, basically, because our assumptions on numbers are wrong.
So, for example, if we assume there's in Canada 35,000 people who are chronically homeless at a given time, or 250,000 who are homeless in a year based on them touching the homeless sector or a point in time count, right? Or shelter utilization numbers. It could be that really there's 100,000 chronically homeless and 750,000 are homeless in a year.
Yeah.
And so if you're looking at our national housing strategy and the types of investments, that might suggest they need to be more than tripled.
Yes, right. In order to Yeah, in order to solve the problem. And the other problem with our current methods is there's a little bit of a vicious circle going on. One of the issues in homelessness is there's a real urban bias in the data. It's very urban centric. So what happens is the urban centers have a homeless sector, therefore they have data, therefore they get funded. The rural communities very often don't have a homeless sector, so they don't have a way of counting it, and then they can't get the services because they have no data, but they have no data because they have no services. So it's kind of a vicious circle. So in some of our work, we've been trying to very consciously include these smaller communities as well. And they're certainly seeing a lot of the same problems, except they have no resources or almost no resources. And, something like, I can't remember because it keeps varying, 68 or 72 communities, whatever, across the whole country that actually contribute to that HIFIS data because they have shelters. So what about everyone else? What about those small communities? So in London, when we were first starting to work in this area, we were finding 20% of people in our shelters were actually coming from those rural communities surrounding London. Because in London, you can go 100 kilometers in any direction before you'd find another community with 100,000 people. So you can't just solve the problem by focusing on the urban center.
I'm recording in British Columbia, and we know that homelessness is provincial, and small and medium-sized cities and villages have the same or even worse homeless problem and prevalence, partly because of what you're talking about, because without the investments, they can't prove it and they don't get them, and then the numbers are getting worse. We even had Dennis Culhane on our first episode, who made the argument that one of the reasons that we're seeing explosive homelessness numbers on the West Coast is a historic lack of investment on the West Coast because they didn't have the agencies to attract the funding, which is very interesting hypothesis, but we're seeing it on a micro level in rural areas, perhaps.
Yeah. And when we look in Ontario, remember I said the legislation communities could opt out of the housing. That very often that was small rural communities that said, well, we don't have these kinds of problems. And maybe at that point they didn't. Why should our taxpayers pay for this problem we don't have?
Now, a second thing that jumps out to me looking at your study using health data to count the potential number of people who are homeless is that a lot of people are touching the healthcare system, potentially even
so
more than the homeless system. So you're
so we know it's still an underestimate. Yeah.
So your research around discharge into homelessness and thinking about how to implement homeless prevention in the healthcare system could have a huge impact. Doesn't this suggest that?
Oh, yeah, because despite it not being perfect, because not everyone accesses healthcare, and I said we were finding about 50% were, and that's why when I say that 3 times, I'm sort of taking that inflation into account. But if that's a major feeder into the system and people are accessing health programs rather than homeless programs, then we are in a terrific position to prevent homelessness. The other thing I'll say too is when we've had those various projects around preventing to discharge homeless, and we work really closely with the City of London, who's the community entity in London, have been of incredible support for us. In fact, after we did our last night, they actually picked up the cost of continuing that. The youth version's been picked up by London Health Science Centre, the hospital, but the city picked up the adult version. So when the study finished, the intervention did not finish. But when we were working with them, we would often find these people that were about to be discharged into homelessness were not on the by name list, were not in the HIFIS data. Very frequently, they would say, well, we didn't even know this person existed. Particularly when we were looking at the medical units, we are finding that, sometimes someone had been homeless for 10 years when coming in their one night in hospital. Well, we can't solve that in one night, right, on the medical units. But what we can do is make sure they're linked into the Housing First programs in the city and then follow them over time. But when we were doing that, we were surprised to find, so here's somebody medically compromised, they're in hospital, but they were not in that data set. So it was really important that we did link them in and we followed them over time. And we found just by doing that in hospital, to link them into those programs when we followed people over the next year, they got housed because even though it was a very short admission, we were able to link them into those bigger programs. But I was so surprised how many times these very vulnerable people were missing from the data.
It seems to me like the silos between the different ministries and agencies, health, housing, income assistance, and the lack of coordination between them is something that keeps coming up. And you've been
Absolutely.
trying to coordinate that. So where do you think we're at in terms of getting to the place where those silos are coordinated enough to make the change that's needed?
Well, we have to work together. There's no one sector that, like, working from health, we could not possibly just purely from health solve the problem of discharge to homelessness if we're not dealing with housing and income support and these housing first programs. But on the same token, those other players could not be as effective without health. So we absolutely have to work together. It doesn't just touch one sector.
Are there any promising signs on the national level, or what are the first steps that need to happen with, say, this new government?
Well, yeah, I think we have to be looking at it cross sectorally. Some of the things we found were really helpful by having all parties there and going across the country. When we did our homelessness count study, we were in 26 communities across the country, every province and territory. And I found very few places other than London did this. And that is our housing advocates in hospital had access to that HIFIS data. They could enter data in, contribute to that integrated intake, et cetera. They were part of the team, so they were not separate. We could often solve problems because we were sharing data at that level. So, for example, many times we would see somebody, for example, was Ontario Works, basic income support, was eligible for disability, but there was no family practitioner who could sign the form. And so we'd find that there had been a form filled out like a year and a half ago, but nobody could sign it. Well, you know what? We got physicians in hospital. Go figure. And we had Ontario Works working with us who would make sure the form was up to date. We could get it signed, and then they would fast track it. They would contact Ontario Works to fast track it. We sometimes had people move to the appropriate income level within the day, which meant you had several hundred extra dollars in terms of finding them appropriate housing. That's huge. But you couldn't do it without that income support, the homeless housing sector, and the healthcare all working together. Because that form, many times, had been sitting there over a year, 18 months, whatever, unsigned because they did not have someone. So it is much easier if we can work together.
Yeah, those are amazing practical implementation steps. And just to ask one more time, what is one big thing that the federal government or the provinces could do to start to spread those procedures across the country?
Well, one big thing is to be looking at affordable housing not as 30% of your base income, but to be looking at what is it that somebody on basic income support, basic disability, and OAS could actually afford to live in, which means public housing. We need a huge investment at public housing that would be available for people at those income levels. If we don't have housing for them at those income levels, then we're going to continue to have a homeless problem.
Now, we know that being stably housed is a really important determinant of health. Stephen Huang, who you mentioned, has talked a lot about that. And given that
Absolutely.
that's true, what would it look like to treat housing as healthcare in Canada, a country where people buy into a universal healthcare system?
The solution is that make sure people are housed. And to see that as a human right. We did sign on to the UN proclamation that housing is a basic human right, but we've already been investigated more than once by the UN for not really following up on that with bad housing policy. So we need to have better housing policy that truly recognize housing is a human right. When we've used that algorithm, we've looked at many diverse health issues and seen incredible overrepresentation of people experiencing homelessness in almost every case. For example, with the opiate crisis, people experiencing homelessness are vastly overrepresented. We found just even on the coroner reports that it was showing 1 in 6 people in our time period leading up to the pandemic who died from an opiate crisis. It's right on the death certificate said they were homeless. How often do you hear housing status when we talk about the opium crisis? And when we used our algorithm, not as high as 1 in 3.
Right. One in three people who died of an OD were homeless.
Yeah. Right.
It's
Had an
unbelievable.
experience of homelessness and on the corners. Yeah, when we used our algorithm.
Yeah.
So within 6 months, either side had had an experience of homelessness. So how do you
Yeah.
solve a problem by ignoring housing? So we've done similar work looking at things like dementias, again, overrepresentation. COVID risk when we did that during the pandemic. So we're paying the money for all these expensive healthcare interventions instead of seeing housing, as you say, as an intervention, which would be much cheaper than the healthcare interventions and much better for the person's quality of life and respect for them as a human being.
Yeah. And I do want to mention something that you've mentioned about overdose deaths and homelessness, that Narcan, which
Yeah.
reverses an overdose, has to be at room temperature. So
Yeah.
one thing that you heard and found was that
Yeah.
people who are homeless in areas where it's too hot or too cold, someone attempted to administer Narcan and it didn't work, and they passed
Yeah.
away.
Yeah. Well, in our study, when we went across country, we had 400 people we interviewed. I personally interviewed about 100 of them. My coordinator another 100, and we had different staff with the other half. And over, I'd hear about the friend that died last week. And they'd often say they're participating in the interview in honor of the friend that died last week. So I'd ask them about that when they're saying that was their motivation. And over, I was hearing about them trying to resuscitate somebody and it not being effective. And in fact, when we looked at that corner data, 50% of the time they actually had somebody with them. Somebody was with the person that died when they were homeless, much higher than the general population. And they would talk about trying to administer, whether it's nasally or injectable, having a plunger and it won't even work because it was frozen, and trying to save a friend and it not working, whether it be too hot or too cold. And that was one of the reasons we wanted to look at that issue, was because people were telling us about this issue.
And this is the big, tough question that I'm trying to figure out, and we're trying to figure out, is given that the cost of homelessness is so high financially, in terms of people's health, in terms of their lives, and there's research, including yours, that is really helping to shine a light on that. Why are we so far behind on ending homelessness?
I think it's about valuing people as people, in all honesty. It boils down to human rights and considering people as having human rights. I think we need to not simply be looking at profit margins. We need to be looking at people. And I think sometimes there's a stigma around homelessness, as there is also around mental illnesses, including addiction. And so when people aren't valued, it can play out in different ways. And I think part of it too is people want to blame the individual because they don't want to see how vulnerable they are personally. You know, if you can say that person made bad choices, that person did dumb things, I make good choices, I do smart things, therefore I'm safe. It's a way of separating yourself from the problem rather than recognizing how vulnerable we all are. And we have to recognize people as people.
Well, I think that's an appropriate final thought for our listeners to contemplate. And I want to thank you so much, Cheryl, for taking the time with us today.
Yeah, thank you.
And your Order of Canada was well-deserved. And most importantly, it's great that you're using that as a platform to talk about this issue.
Yes, thank you so much.
This episode of Policy Crimes was produced with Lena Moskaleva and CJ Tremblay. Original music by Matt Hayter. This podcast is a project of the Publication Cooperative. If you have thoughts, feedback, or ideas, you can email us at policycrimes@thepublication.ca. Thanks for listening. See you next time.